or Huntington's disease. This is another sad condition, but unlike Parkinson's, wherein you develop it later in life, this one, because that was degenerative, this one is hereditary. Huntington disease is a chronic, progressive hereditary disease. Now, this, unlike again Parkinson's, which is degenerative, this one you were born with it. To make matters worse is you do not, if you have the disease, you don't develop it until you're in your 30s. Meaning you have the gene, right? You got it from a parent. You do not develop the disease until you're in your 30s. So,
I'm sorry, Professor. Can you let Unique in, please?
okay. Thank you. Okay, I repeat. This condition is genetic. It's hereditary. So if your parent or grandparent passed it to you, you don't develop the disease until you're in your 30s. So the disease is characterized by progressive involuntary coriform movement, and dementia. Now, what is coriform? Coriform comes from the word choreography. What is choreography? It's like a dance move, yeah? So these are dance-like movements. But unlike choreography as you know it, this is not a nice dance. All right? These are uncontrollable, involuntary dance-like movements. They resemble the dyskinesia movements, you know, the tardive dyskinesia movements. But unlike tardive dyskinesia, this one is worse. This is the entire body. So if the patient does not stay still because they keep doing the movements, and by the way, the movement is never the same. It's not like, you know, like you do the Roger Rabbit, for instance, or whatever dance move wherein it's repetitive, you know, the same dance. This dance is never the same. It's different each time, and again, it develops later in life, usually midlife, but it can start as early as in your 30s. So how old is everybody here? You're about, um, average age here is about 30, yeah? Or maybe 28. So if you develop the disorder, that means if you have it, then you have a great chance of passing it on to your children. So knowing, let's say, well, the problem is you don't develop it until later in midlife. So unless you know that you have it, then you can possibly prepare ahead and not have biologic children, because that's the only way you can stop the disease. You agree? But if, let's say, you're the type that, oh, I want my genes to move on, yeah, I gotta have children. Well, yeah, your children have a 50% chance of getting it too. So do you really want to pass this on? I mean, is your gene really that important to you?
No, I would have put nobody through that.
Okay, but again, we can't force people, you know, but part of the disease management will be genetic counseling. If patients will be seen, you know, by a genetic counselor and talk about, you know, maybe we should end your procreation, you know, I mean, if you want to have children, probably not biologic. Because if you choose, I mean, you can choose to, let's say, um, do in vitro fertilization and then just decide which embryos, and you know, test the embryo. Whichever embryo doesn't have the disease, then those will be the ones you will implant. but that involves a lot of money. Yeah. So yeah, you have the chance, you have the option to do that, but again, that costs a lot of money.
So, Professor, would you say the people who choose to have these the babies with this type of gene selfish?
Say again.
So would you call the parents that still accept the terms of passing on this gene to their offspring? Was that what I say? Selfish? Yeah.
I wouldn't say that. I would. Well, I don't want to say it really.
Off topic, off the record. No one's recording here.
Well, I am recording.
Oh,
But
you're
I
right.
don't wanna say it. I don't want to say it. But I mean, it's a free country, like I always say.
You're right. You're right.
But just think, you're passing it on. You're perpetuating the disorder.
So they are selfish. Got it.
I didn't say
No,
that. I'll leave you.
That's what honestly what it is. You're just keeping this gene going.
Okay. That's true too. Um, so here are the manifestations. So the major problem, you can look on YouTube. There are a few. There's not a lot of videos on Huntington disease. I mean, I wouldn't post this on YouTube either. But I would say, just to educate people about the disease, the disease condition. So there's chorea, rapid, jerky, involuntarily purposeless movements. Patient has no control here. Now, unlike Parkinson's, wherein, yes, some Parkinson's patients develop dementia over time, these patients are guaranteed to develop dementia. They do eventually, only a few years. It's also fast developing the dementia. So a few years after they develop the symptoms of the disease, then they develop dementia as well. Now, the sad part about this is, remember, it doesn't develop until later in life. Yeah. So from birth to, let's say, midlife, they were living normal lives, absolutely normal lives. So they have a career, they have a family, and then boom, it hits them midlife, 40s or late 30s, 50s, they develop the disorder. Okay, so that's the sad part about it. And just imagine if you have these movements, okay, and they don't stop. How can you do anything? I mean, chewing, eating. Okay, let's just talk about basic stuff. So chewing and eating, how can you do that if you're moving nonstop? Okay, so you have these dance-like, rapid, jerky, involuntary, purposeless movements. This is from head to toe. It'll be hard to even ambulate. And the patient has no control over the movements whatsoever. So they have these facial tics, grimaces, slurred speech, and then eventually unintelligible speech. And just like in Parkinson's, they're high risk for choking and aspiration. They even persist during sleep. At least they get diminished, so the patient can sleep somehow. But so what will happen to these patients? Imagine this is the manifestation. So how much calories do they burn through every day? They're moving nonstop.
Tons.
And then how much can they eat?
Not much.
A little bit.
Okay, so nutrition and muscle wasting is a concern here. Yeah. And the ambulation already said, so it interferes with the most basic of things. They can be confined to bed when the movements are now uncontrollable, okay, for safety, because if they get out of bed, they'll surely bump into stuff and then fall. Then cognitive impairment, like I said, they will develop dementia eventually. Okay. And it's guaranteed. Okay, this is not like an if, unlike in Parkinson's, wherein some patients do, some patients may not develop dementia. And then there's behavior changes as the disease progresses, and eventually, you think they will live normal lives. I mean, the regular lifespan, normal lifespan.
No.
No.
No, these people will die early. So again, onset is around this age, so around midlife. Very few are going to develop it as a child. So most cases, a majority of cases will be developing later in adult life. Management. Well, there's none. There's no cure for the condition. So management will be mostly symptomatic. Do you remember the drugs we used for Parkinson's earlier? Same drugs to control the muscle movements. It will help with the symptoms. So this is the most commonly used drugs. And like I said, we can use sedatives, so benzodiazepines, to control the movements. But of course, when we use these drugs, so what will happen to the patient? These are sedatives.
There would be sleep.
Okay, that's all these drugs will do. Okay, so they just put the patient out. They'll be in bed, but at least the the movement stop. But again, they can't do anything besides sleep. And as already mentioned, so they'll benefit from the same medications we use for Parkinson's disease. But the result again is they'll be confined to bed. That's about it. And here are your teaching for the patient. So medications with safety during mealtime, aspiration precautions. So majority of the patients, if not at home, they will be institutionalized because the family can't provide this level of care. Okay? I mean, this is a 24/7 level of care. Any questions on Huntington's? All right, let's go to multiple sclerosis. Okay, so multiple sclerosis is under 64 because this is autoimmune. Have we done Guillain-Barré syndrome?
Yes.
Okay.
Yes, Professor.
Okay, so this is the last of the neurologic, and then we can begin respiratory on the last hour today. So what is MS? This is autoimmune progressive demyelinating disease of the CNS. Again, autoimmune progressive demyelinating disease of the CNS. So this is your nerve. There's the axon and the dendrites. Okay, so we have millions of these. They make nerve impulse transmission possible through your muscles and makes movement possible and smooth. The problem here is this myelin right here in letter D is destroyed. Now it's not destroyed all throughout. So meaning there will be continuous patches of intact myelin, but then some sections will have destruction. So what will happen to your movement? Can the electrical impulse travel smoothly?
No.
It will be interrupted at some point. So whichever parts of your muscles have demyelination, then there will be interruption in the movement. Meaning when you pick up something, for instance, okay, so I'll pick up this pen on my table. It's easy for me to do that because I don't have MS. Now, if patients have MS, will they be able to smoothly perform that basic function? No, there will be interruption. So there will be some tremors. They'll have difficulty performing that simple task. That's MS. We also heard major celebrities still living now that have MS. And it's a sad disorder. There's no cure for this either, as with any other autoimmune disorder. We don't know what causes this. Again, it's autoimmune. We really have no idea what causes autoimmune disorders. So this is what we know about the disease. So we have autoantibodies destroying these myelin sheets. But surprisingly, it doesn't destroy all though. So it almost like randomly, the destruction is random. So there are different types, but the most common type is we'll discuss is the remitting and relapsing type. Okay, so again, the most common type, which is remitting and relapsing type. So this is chronic. So these patients will have good days and then they'll have some bad days, meaning they will have some exacerbations. Okay, but it's possible to live for them to live relatively normal lives with medication, as long as they have good support from their medical professionals and of course family support. Manifestations. Okay, so it's a movement disorder. So the problem really is with the tremor. Now, if you recall, when did the tremors occur in Parkinson's disease? Was the tremor at rest or on movement?
At rest.
At rest, correct. So that if you notice Michael J. Fox, he purposely continues to move. If you've ever seen him on interviews on camera, he will sway from side to side. So when he figured out that if he keeps moving, as long as that movement, is not weird, as long as he, let's say, if he's sitting, he'll maybe, sway from side to side. He can control the tremors. Now, because the tremors come on when he's not moving. So, so in MS, it's the other way around. These patients will have tremors when they move. So we call it purposeful tremors. Whereas in Parkinson's, it was resting tremors. So these patients do not have the tremors when they're resting. It's really on movement, which coincides with the pathophysiology because of the demyelinated sections of the nerves. Then it will make sense that they will manifest tremors when they're moving.
Excuse me, Professor, can you please let Shanice in?
Recording it.
Okay, can you hear me?
Yes, Professor.
So
Yeah.
again, this is the majority type. So this is what we'll be discussing and testing. So RRMS, which is relapsing remitting type of multiple sclerosis. So that's 85% of all cases. So manifestations will be, besides this tremor, the patient will have the fatigue. Okay. So when you have fatigue, can you keep and maintain a job? Or very, very difficult, yeah? So fatigue is the overwhelming complaint. And then what's the age, by the way, that this is affected? Go back to here. So what age group is affected here? between
20
20
to
and
40.
50.
20 to 50.
So what are 20 and 50 years of age people doing?
Having fun, living life.
Enjoying life.
All right, so these are your most productive years. Okay, and then you're affected during that age group. So besides fatigue, what will you develop?
Depression.
Correct. Among other things, yeah. So you'll you'll start having anxiety because can you help comparing yourself with other people?
No.
No, your peers are now, they're enjoying, and then you're on social media, you see all they're posting, oh, they're having so much fun. Here you are in bed, at home, on your couch, in pain, fatigue, just miserable. Okay, you cannot do anything. There's pain. There's pain here and spasticity. Your muscles and joints are painful. On top of that, most cases why they cannot hold a job anymore is the visual problems. So they'll have double and blurred vision as well. So you cannot name a job now that doesn't require a computer. None, right? I mean, the most menial job still requires you to log in somewhere, right? To do something, even though that's not majority of your job. So these visual changes will literally disable the patient. So they go on disability because of the visual changes. They can't do anything. And because of the fatigue, now the patient is forced to stay at home in bed or on the couch. And then can that lead to muscle wasting now and muscle deconditioning?
Yes.
All right. So that will result. So it'll be a snowballing effect. Okay, so one symptom can lead to others. And describe the appetite here and nutrition.
It'll be small because of the fatigue.
Okay, yeah, and then so they'll stop eating, or maybe if they have enough energy, they may overeat. That's possible also, but with fatigue, I doubt if they'll overeat. All right, let's go to treatment now. So it's autoimmune. So what can we do for autoimmune disorders?
Immunosuppressants.
Very good. So that will be the bulk of the therapy. So for spasticity, we will give them muscle relaxants for that. We have a list of drugs under management. There will be some bowel and bladder control, and will they have good libido here if you have this disorder? I mean, you have the desire for sex.
No.
All right, so these are problematic as well. So even if the patient does have libido, the partner may not have the same or may not reciprocate it because the patient have some bowel and bladder problems, meaning they'll have some incontinence. And then, of course, with all of these, this will result in the following complications. Okay, so they'll have marital problems eventually, they'll go on disability, and then financial constraints and difficulty will eventually follow. Here's the management. Since there's no cure, as with any other autoimmune disorders, we have medications only. All right, let's start with the drugs. So remember rheumatoid arthritis, which was also autoimmune?
Yes.
Okay, so similar medications. So some medications here you'll see that you'll remember from rheumatoid arthritis. Now, what will benefit these patients is Copaxone, which is here. They are interferons. These are subcutaneous injections. They'll do at home themselves. So when they take these medications, this will put them into remission, and allow them to function so they can go back to school, they can hold a job, they can perform their roles as a mom, as a wife. All right. So this will enable them to again go back to society. Okay. However, as with any other autoimmune treatment, which are immunosuppressants, what's your number one side effect?
Infection.
Infection.
Okay, you're at risk for high risk for infection. And then among those, so the leukopenia here, of course, will drop your which means your WBC count are low, putting you at risk for infection. And there's hepatotoxicity here, so we need to monitor your liver function while you're on these treatments. Glatiramer acetate. This is PO. No, sorry. This is sub-Q. It is the fingolimod is the PO drug. So these are your injectables. Okay, these are PO now. Fingolimod is very popular. Okay, so if the patient can't tolerate the injections, then these are the PO or oral options. But the subcutaneous injections are more effective. If the patient has an exacerbation, as with any other autoimmune disorder, they have flare-ups, yeah? That's why we call the disease a remitting, relapsing type of MS. So when they are in exacerbation, meaning they have a relapse, they'll be placed on high-dose IV steroids. So they'll be hospitalized for these, and how do we discharge you on steroids again? We taper it, yeah? So after the high dose, then we'll begin to taper it, and then put you on PO eventually, then kick you out of the hospital, then you continue the taper dosing of oral steroids at home. This is a IV infusion option. Have you seen this drug in cancer? This is a chemo drug. So this is one option also. And as with any other chronic disorder, so with Parkinson's, Huntington's, we have drugs to manage the symptoms. So do we give them muscle relaxants? Do we give them antidepressants?
Yes.
Do we give them anti-anxieties? Sleep
Yes.
aids? All right. These are the other medications. Nothing to do with the disease. It doesn't modify the disease unlike these drugs mentioned in the previous paragraph. These will help with the disease itself, because it's autoimmune. So therefore, the immunosuppressant therapy will help with the disorder. However, we need to manage the patient's symptoms as well, meaning the complications associated with the chronic progressive disorder. So muscle relaxants, antidepressants, anticonvulsions. Now the anticonvulsions here are not because they have seizures, but because of the pain that they have. Now this pain is neuropathic in nature, so they benefit more from anti-seizure medications. And remember amantadine? This was given in which patient again? This is an antiviral. We did it earlier.
Parkinson.
Okay, this was given to Parkinson's as well. So they'll benefit from this as well, because they do have muscle movement disorders after all. And we have to manage these as well. So if they have the overactive bladder, they'll be placed on those bladder medications, okay, overactive bladder medications. And then because they do have incontinence, then UTI will be common in these patients. By the way, majority of MS patients are female. Okay, more than half of MS patients are female for some reason. That's it for MS. Any questions?
My Wi-Fi had one out, so I missed the beginning of this topic. With MS, do you know you have it like from birth, or do like
Oh,
something
no,
happen?
no, this is autoimmune.
Oh, okay.
And again, the age of onset is between 20 and 50 years old,
All right.
right here. So you're still within that age range. So you could, in your female, then you could still have it.
Okay.
Females 3 times more than men. Any questions on MS? That's